We'll now turn to hear from Monika Schneider, a research associate within the Biomedical Innovation Team at the Duke-Margolis Center for Health Policy, and she joins us today to share their work on incentives for antimicrobial product development. Monika?
Great, thank you. I'm really pleased to be a part of this discussion today. I'll be covering some of the economic strategies that can be used to incentivize antimicrobial drug development. So bacterial resistance to antibiotics is driven in part by overuse and inappropriate use of these drugs. In the U.S., we spend a lot of money on a lot of antibiotic prescriptions, but about a third of those are unnecessary. Any use of antibiotics can drive resistance, and inappropriate use unnecessarily decreases the effectiveness of these drugs. So antimicrobial resistant infections also significantly drive up healthcare costs during an episode of infection. So novel antibiotics are needed to treat these infections and bring down this cost. Unfortunately, there are currently less than 50 antimicrobial drug candidates in development, and of these, there are very few that can eliminate high-priority drug-resistant infections. As was touched on by Dimitri just in the previous presentation, the reason for this lack of development is largely financial. Companies who develop antibiotics receive a very low return on investment relative to the public health benefits that are provided by these drugs. Several issues contribute to low return on investment. First, clinical development for these drugs can be very costly, especially if they're designed for a limited patient population, like those who acquire drug-resistant infections. Second, a lack of rapid diagnostics to detect infections can mean that enrolling enough patients in a clinical trial can take longer and be more costly. And then once a novel antibiotic is approved, it will generally be kept on the shelf until it is really needed, and that is usually when resistance develops to the standard of care. So this is considered good stewardship practice. We don't want to have to use these novel drugs right away because using them means that the bacteria will have a chance to develop resistance as well. However, the low volume of use means that manufacturers make very little money off of these drugs, even if they charge a high price for use. And then finally, the health benefits that accrue to non-antibiotic users are not represented in the price of the drug. The lack of antibiotics is a global concern, and there have been several international organizations who have been exploring ways to better incentivize innovative antimicrobial development. And these include the Chatham House, Review on Antimicrobial Resistance out of the UK, the German Global Union for Antibiotics Research and Development, and the European group DRIVE-AB. And while there's some specifics, while the specifics vary in each of these reports, there's been a convergence on several key principles. First, there needs to be an increase in funding dedicated to basic and translational research on antimicrobials. Second, there needs to be some sort of incentive mechanism that is provided once an antibiotic has been approved that will de-link reimbursement from sales volume. And finally, there needs to be a global effort to coordinate on surveillance, stewardship, and development. The U.S. has also been making efforts to address this problem. In 2012, Congress passed the Generating Antibiotic Incentives Now, or the GAIN Act, which grants additional market exclusivity to qualified infectious disease products. Over the past 6 years, there have been more than 140 drug candidates that have qualified for this program, and only 12 drugs have actually received approval. One of the limits of this incentive is that it does not address the issue of low-volume sales. So if an antibiotic is not sold in high numbers, then the additional years of exclusivity will only bring minimal revenue and is not going to significantly impact the return on investment. More recently, as was just discussed, the Limited Population Antimicrobial Drug Pathway, or LPAD, was passed as part of the 21st Century Cures Act. And this is for treating urgent medical needs that can be approved through clinical trials that have a smaller patient population, which should cut down on the time and expense of the trial for the developer. But this means that the drug will also only be available for use for a limited population of patients. So it further lessens the potential volume of use and potential revenue from the drug. There are other legislative proposals that have been put forward to try to encourage development of antibiotics. These include the Disarm Act, which would provide an add-on payment for antimicrobials that are administered as part of a DRG. There's the Revamp Act, which would give transferable market exclusivity to qualified products, which I'll talk a little bit more in the next slides. And then there's the Improving Access for Affordable Prescription Drugs Act, which included a prize fund for approval of innovative antimicrobial drugs. So all these proposals attack the problem in different ways, and each have their benefits and limitations, but none have made it very far in the legislative process. So there's still work to be done in this area. There are several executive efforts that have been going on concurrently to the legislative efforts. In 2014, the White House released the National Strategy for Combating Antibiotic-Resistant Bacteria, or CARB, which led to the formation of the group PAVE, who has released recommendations on all aspects of the AMR problem. For economic incentives, they recommended a combination of general and targeted incentives, including expanded R&D funding and implementation of a delinkage model. There have also been a couple of important public-private partnership initiatives that have been formed. One is CARB-X, which provides funds for projects in preclinical phases of development. And then there's BARDA, which has a program that supports companies through clinical development. And both of these organizations are important for helping companies get their product to the market. But without a predictable source of revenue upon approval, there will be limits to how successful any of these companies can be. So I just talked about some of the different programs that are meant to incentivize antibiotic development, and I wanted to show how these fit on the spectrum of a typical pipeline for drug development. There are essentially two main types of incentives. Push incentives, which are shown on the right side of this picture, focus on reducing the left side of this picture, that focus on reducing the R&D costs for new antimicrobials by providing financial and infrastructure support. And they can include things like NIH grant funding, tax credits for antimicrobial R&D. BARDA and CARB-X programs would be considered push incentives, as would the LPAD pathway. And then there are pull incentives, which reward manufacturers after an antimicrobial enters the market, increasing the potential revenue. And this can include the GAIN Act, the additional market exclusivity. It could be disarms add-on payments. And it also includes various delinking mechanisms, such as a market entry reward. And market entry rewards have been recommended by several groups, and essentially they provide a lump sum of money to an antibiotic manufacturer once the product has been approved, which removes the need for generating revenue through high sales. So the market entry reward is the favored delinkage model because a lot of the analyses by the other groups have looked at this, have shown that this type of reward would best reflect the public health benefits that these high-priority antimicrobials can bring. So a market entry reward would complement the early-stage support that is being provided through CARB-X and BARDA. Unfortunately, due to the very large dollar amount that is attached to this type of reward, and it's been estimated between $1 to $4 billion globally, funding this type of pull incentive is a major barrier to implementation. The other type of pull incentive that has been prioritized in the U.S. is the transferable exclusivity voucher. This mechanism would award to manufacturers who successfully develop an innovative antibiotic an additional 6 to 12 months of market exclusivity. But this exclusivity, unlike the GAIN Act, would be able to be transferred to a different or probably more profitable product that's in the company's portfolio, or the receiving company could sell their voucher to another company. So return on investment would be generated through sales of a different product or through proceeds of the sale of the exclusivity. This mechanism is attractive because it provides a financial incentive that does not rely on the volume of antibiotics sold, and it does not require a large sum of money to be appropriated by Congress. However, a transferable exclusivity voucher would increase the price of a different drug by delaying the entry of generic options, and it does not necessarily directly address the issues with fee-for-service sale of antibiotics. So looking at some of the best qualities from these options, we want an incentive that is able to leverage existing antimicrobial payments to limit the need for public funding. We want them to limit increases in other drug prices and spending, and we want to reinforce the trend towards paying for value in healthcare. So when we first began this project at Duke-Margolis, we were interested in identifying pull incentives that would be most appropriate for the U.S. And we wanted to outline a feasible approach for implementation of this incentive. In order to do this, we engaged with a broad group of stakeholders that included manufacturers, payers, providers, government agencies, including support from the FDA, and patient representatives to identify and examine promising proposals and other potential models. Following our research and discussion with stakeholders, we arrived at several core principles, which I have listed here. And importantly, we wanted an incentive that could be a part of a comprehensive strategy of both push and pull incentives. We thought the incentive should provide developers with rapid access to funds upon market entry, that the incentive should align with broader shifts in payment away from volume to reward higher quality and value, and an incentive that would have public funding that would be complemented with private payments. So traditional fee-for-service payments are volume-based and do not support high-value and appropriate use of antibiotics. But there is an opportunity to bring the current payments for antibiotics in line with payment reforms that are current throughout the healthcare system. So in general, there's been a greater emphasis on value and quality in care delivery in the U.S. Many of these changes have been focused on provider care delivery and have taken the form of patient and episode-level alternative payment models. These models shift away from high-volume and high-intensity care by allowing more flexibility in how services are provided and providing higher payments for better measured results and lower overall costs. These alternative payment models also provide more support for care coordination and innovative delivery of care. However, they create more accountability for providers and can impact the incentives to use high-cost therapies that have a low impact on patient outcomes. So in essence, emphasizing quality and value in payment reform can create new opportunities and motivation for how drugs are reimbursed. And these concepts play into our recommended payment model for antibiotics. In our proposal, in order to qualify for the reward, an independent panel would set eligibility criteria that is aligned with current unmet medical need and would provide a list of desired R&D targets. Once a qualified drug has been approved, the manufacturer would receive award payments, and these payments would be delinked and would align with the global recommendations for AMR incentives, similar to the market entry award, and this amount would be paid out over a number of years. The payment that manufacturers receive for their drug would be a benchmark payment to reflect the innovation and value to public health in a tiered manner. And since the full reward amount would be paid out over a number of years, continued payments would be dependent on the availability of the drug, proper stewardship, and a transition to population-based APM contracts with payers. Our proposed model, which we are calling the Priority Antimicrobial Value and Entry Award, or PAVE, utilizes a phased-in approach to value-based reimbursement. So building upon the market entry reward, which would be given over the first few years of the model, manufacturers would be expected to transition to and engage in population-based payments for the antimicrobial with payers, which would supplant volume-based fee-for-service payments, continuing to delink revenues from the volume of drug used. Additionally, aligning payments with appropriate use would encourage all parties to support needed stewardship efforts. So key features of this model include a strong incentive for innovation due to predictable return on investment, changes to the structure of antimicrobial payments without significantly increasing the amount that is currently spent on antimicrobial drugs. There would be a combination of public and private funding to accomplish delinkage, as well as to support stewardship and drug availability. And it would provide a direct incentive to shift away from paying for antibiotics based on the volume used. So to illustrate how we envision this model to work, on the left side, this graph shows the proportion of revenue coming from various sources. And these numbers are illustrative, just to kind of give you an idea of how we envision this model working. The blue represents revenue from the market entry reward, the green represents fee-for-service revenue, and the yellow represents revenue from value-based payment contracts between the manufacturer and payers. So as you can see, in the first year or two, the majority of revenue will be coming from the market entry reward. But as time goes on, the manufacturer would begin to establish contracts with payers for population-based payments, and the proportion of revenue from this source would increase over time. This model still allows that some revenue can come from fee-for-service payments, but it will be far less than under the traditional payment models that we have today. So under our current payment system, all revenue is coming from fee-for-service. On the right side, this graph shows how a manufacturer could reach revenues of the recommended $1 billion. Again, the blue represents what would be coming from the market entry reward, while the green is fee-for-service and yellow is value-based contracts. The amount shown in yellow and green is a rough estimation of what antibiotic manufacturers might hope to make if their drug is commercially successful. So in the PAVE model, public funding from the market entry reward would supplement that amount. So there are still several outstanding issues and other considerations that will need to be worked out before any sort of implementation of this award. So there need to be some guardrails in place to ensure that value is delivered to all stakeholders. For example, payments for the antimicrobial would not just be given and not expect anything in return. The manufacturer would be expected to have continued data collection on the drug's use, as well as committing to the guaranteed availability of the drug. It will also be necessary for payers and providers to enact strong stewardship guidelines, which could include clear protocols for appropriate drug use and giving greater thought to how drugs are priced so that there's not an incentive to just reach for the cheap generic right away. We also need to consider that there might be some infections that are so infrequent that it may be more appropriate to consider a market entry reward only option because the drug itself might be used so infrequently that there is no incentive to do some contracting. Implementation will be dependent on measurement of value, which will need to be further defined. But the measures could build on those that are available today, including those that pertain to ongoing availability, utility, and access measures, as well as use data. We've also considered that initial payer participation could be challenging, particularly since long-term savings are difficult to account for with near-term payments. So implementation will require broad buy-in from the payer community. Also, antimicrobial use and how antimicrobials are paid for varies based on whether they are administered in the inpatient or the outpatient setting, and the guidelines and outcomes that govern the PAVE award model for these high-priority inpatient antimicrobials may need to be adjusted to be applicable within the outpatient setting. So I will stop there and, be happy to take any questions at the end of the webinar. Thank you.